Welcome to the Movement Prescription Podcast from the British Society of Lifestyle Medicine, the show where we explore how physical activity can be used as a powerful, practical tool in everyday healthcare. I'm your host, Dr. Hussain Al-Zubaidi, and in this episode, we focus on a part of healthcare where we don't always talk about movement enough, the perioperative period. Surgery is often seen as something that happens to patients. But what if we reframed it as something patients can actively prepare for and recover from, with physical activity as a core part of treatment, not an afterthought? I am delighted to be joined by my friend, Professor Scarlett McNally, orthopedic surgeon, national clinical leader, and a long-standing advocate for making physical activity routine across healthcare systems. Scarlett has been instrumental in championing prehabilitation, early mobilization, and the idea that movement is not simply safe around surgery. It's often one of the most effective interventions we have. In this episode, we explore the evidence behind preoperative activity, how much movement really makes a difference, practical behavior change strategies, and what needs to shift at a system level so that movement as medicine becomes standard surgical care rather than the exception. If you work in primary care, surgery, rehabilitation, or community health, or from the physical activity sector, this one's for you. Hello, Scarlett. Great to have you on the Movement Prescription Podcast. How are you?
Very well, thank you. Yes.
Really appreciate you giving up the time. And we had such a myriad of speakers and professionals come onto this podcast from different realms. But I was really excited to get you on because every time I see you talk and I see you present, there's always so much energy, and everyone that knows you just loves the passion that you have. So I'd love to find out, where has this passion come from? Why does physical activity mean this to you?
Well, so I'm a surgeon and I've been a doctor for 35 years. And I was on the Council of the Royal College of Surgeons of England representing that college at the Academy of Medical Royal Colleges about health inequalities. And at the time, this is like 2014, we realised that there are huge differences in health across different types of populations. So we were collecting numbers, but there wasn't anything obvious to do about it. And at the time, people knew about smoking and nutrition and so forth, but there wasn't much about exercise. So anyway, what we did was collated all the evidence about if you do some exercise, does it reduce your risk of certain conditions? And basically, yes, it does. And there's 200 references in the report that I ended up leading that show that if you do exercise, it reduces your risk of dementia 30%, diabetes 40%, depression 30%. And does it treat those conditions? Yes, it does. And you're less likely to break your hip. It's all that stuff. So Exercise, the Miracle Cure came out in 2015. And it was dumbing down that information, as it were, so that people can read it. And it wasn't anything that other people hadn't been saying, but it just felt so important to get that out there as a way of improving people's health. And it's just rocketed from there.
And from your experience as a surgeon, is sort of increasing your physical activity, improving your fitness, is that something that most patients want to either get as an outcome post-operation or as something to prepare themselves for the operation? What's kind of been your insights from the patients that you've managed?
So most patients don't know about this. And the public and a lot of NHS staff still think about rest as being the way forward. And particularly, I'm an orthopedic surgeon. People particularly think, oh, I shouldn't be doing something because I'll make it worse, or I've got a condition caused by wear and tear. I shouldn't be doing anything that makes it worse. Whereas actually, we don't know what causes pain. And there are now new resources showing what people can do when they have an orthopedic problem to keep them active. It just changes what you do. It shouldn't change the fact that you should do something.
And when people talk about the perioperative period, what does that actually include? Like, what are the timeframes that we're talking about?
So the perioperative phase is everything from the moment an operation's contemplated until full recovery at home, not just in the recovery ward. And that would include people who are considering an operation but then don't have it. So, because some people get better or change their mind or other things intervene, and actually exercise does reduce people's need for knee replacement, for example. But basically, it's the entire phase. So it's preparation for surgery, the operation phase itself, and the recovery, and then the rehabilitation and getting better afterwards. So it's all of it.
Yeah, and in lifestyle medicine, we often talk about inspirational moments, key moments where there can sometimes be weakening in the walls to allow behavior change to be maybe a bit more likely to achieve, whether it's a new diagnosis or a change in circumstances. Would you say the perioperative period is that potential moment, or would you say it's challenging time to instigate lifestyle changes?
I think it absolutely is, we call it a teachable moment. So for a number of people, you carry on living your life and you don't change something unless you have to. You adjust when the kids move to secondary school or something, but you don't otherwise make big changes in your life. And this is, for many people, getting a diagnosis or about to have an operation is a big wake-up call, because otherwise lives are so busy and it's very difficult to change.
Fair enough. And let's say we do have someone that wants to or is motivated to make those changes. What would you say are the biggest modifiable factors influencing surgical outcomes today?
So actually there are 7.
Okay.
So there is a website, cpoc.org.uk, Centre for Perioperative Care, cpoc.org.uk. And I was deputy director there for 6 years. I've just finished. And it's hosted at the Royal College of Anaesthetists. And we have 7 pages on the things people can do if they're preparing for an operation. So stopping smoking is the big one. It halves the risk of complications. Exercise reduces complications around 50%. Nutrition's around 40%. There's not so many studies on that. And then practical preparation, not just for the operation, but for the time afterwards, so that you feel empowered, you're ready, and you're far more likely to be a day case if you do all of this. And then psychological preparation, so that you're getting some sleep, you're ready for it, you feel empowered. All of these things matter and do make a difference. The evidence hasn't been collected, I'm going to say. And then getting the kind of the medical things sorted, which doesn't have to necessarily be the doctor doing that, but about a quarter of people who come to preoperative assessment can't go straight forward because they have a medical problem, such as anemia, diabetes, hypertension, and so forth. And about a quarter of the cancellations on the day are because of a medical condition. So all of that, better management, and actually exercise is a huge influencer on those, on the better management.
And how strong would you say these interventions are if we compared them to, whether there be medical or further other investigations that you may want to do during that period? Like, are they comparable in terms of the benefits?
So I'm a surgeon, and I'm going to say this is better than the medical stuff, because this makes a difference to everybody. Because particularly with the exercise, it isn't just being a bit fitter to get through the anaesthetic. It also, you get the endorphins. So you can manage pain. It helps with pain management. You feel empowered. You feel you'll have things under control. And then the very practical thing of your legs are strong so you can get to the toilet by yourself. So you're not waiting for someone to come and help you with the bedpan or you can be in control much more, and you're more likely your surgery on a day case basis if the pathway allows that. So actually, though, it does really make a difference. And we got the evidence now of why. And similarly, you've built up muscle, and muscle's a store of protein, which helps for wound healing. It helps for antibodies. So basically it's a win-win because people are 4 times more likely to have a complication if they're physically inactive, and over 4 times more likely if they're frail, which is not having enough muscle mass. These are they're very important interventions, and they work at tiny doses. Whereas, as I said, a quarter of elective patients are cancelled. That of the ones cancelled on the day, a quarter is because of medical issues that many that people knew about, but just haven't been quite optimized. And, I haven't really seen HbA1cs come down quickly for diabetes. All of these things that we try are not, I'm going to say, my experience, they're not nearly as effective as exercise and nutrition and as I say, stopping smoking.
In terms of realistically supporting our patients that maybe are very sedentary, let's say doing less than 30 minutes a week, is there a worthwhile minimum dose of increased activity that's still going to make a tangible difference before a surgery? So if I'm in an appointment with a patient, and can I realistically say just even doing 10 or 15 minutes more per week will make a difference? Yes. Or is there some other figure that I should be looking for?
Yes, just doing something, just getting up and shaking it all about, walking around the block, getting up and moving, breaking up sedentary time, all of that makes a difference. And in fact, the biggest difference is when people move from nothing at all, as in less than 30 minutes per week, to 30 minutes in a week. That actually is the biggest reduction in risk. So there's nothing, I'm going to say nothing to lose, just do something and then do a bit more.
And that will mean something in terms of reducing that risk before the surgery.
Yes.
Okay. And how about you? How do you fit in time to exercise, given, you've got more roles than I care to even remember when I was doing a bit of research before this podcast? How do you fit it in?
So I cycle to work. And in fact, I've just done a clinic and I've cycled back across Eastbourne. It took longer than I planned because it was raining. So I put my waterproof trousers on and I had to get my hood out of the thing. But it's great, past all the traffic, get going. And actually that works for me because everyone should be aiming at a minimum of 150 minutes per week. So it's about 22 minutes a day. So yeah, cycle to work, cycle home, that would be enough. But actually, I go out on an electric mountain bike when I can, and I've got a house with lots of stairs, and I sometimes deliberately go up and down a few times because partly because I'm a bit forgetful, but I know it's good for me.
Yeah, definitely. Because when I'm on the phone to my dad, it's often quite long, so I just sort of generally wander around the house, going up and down the stairs. Just I do mainly the listening in that conversation, and yeah, just finding moments like that, even the stairs. Think of it as an exercise device in your house. I like that. Okay. Now, in reality, many patients can be quite anxious, in pain, or they feel that they should rest. As you mentioned before, rest is best, before surgery. Like, any tips on how we can reframe that?
It's so difficult because what we really need to do is get into the mainstream media or soap operas or something. But it's to change the expectation and the mentality. It's getting people's family members to come into the clinic or the consultation as well so that they're committed to whatever happens. But sometimes some very simple messages do work. I've just submitted my latest BMJ article. I write in the British Medical Journal every couple of weeks. On the new cancer plan, saying what we also need to do is get the exercise in alongside because it really helps people's preparation for cancer treatment and recovery.
Oh, 100%. I'm actually putting together an article and like a video teach on that very topic. And I actually was blown away by the impacts that it has in terms of cancer survivorship. And because you obviously know about the improvements in terms of prevention and reducing the potential risk of having cancer, but I didn't know just how impactful movement can be even during the diagnosis, or if you've been doing it before, once you've got the diagnosis, in terms of the outcomes, which, I thought was brilliant. Now, one thing that I often get from patients is they can be worried that if they start being physically active before the surgery, that a lot of the benefits that they gain will be lost because they're going to be off their feet for one reason or another. Let's say they're having a certain procedure, which means they're less mobile. What would your advice be to a patient like that who's worried that, what's the point of putting in the work now because I'm just going to lose it in a few weeks?
But just put in the work because it is so worth it, and you have that store of muscle. Your body kind of learns how to get into the habit so that then you can count the days until you're allowed to do stuff again and then get going again, and that will benefit your future life. Yeah, I mean, as an aside, I know what they mean. I had a couple of procedures last year. I had a cardiac ablation, and for that you can't move because it's a little nick in a vein in the groin, and you're not allowed to move. And I had the big plummeting endorphin, loss of endorphins from not being able to do anything. So I had to do lots of writing and reading. I found it very frustrating.
I can imagine.
But equally, I had a hip replacement last year, and I knew I could get fit beforehand. And I got fit. I went out on my electric bike every day because I couldn't, my hip hurt, but it could go up and down. I'd wake up at night because it was so painful because I twisted, and it would be painful when I twisted, and I couldn't get off the bike once I got to finish my ride. I had to do a very funny maneuver where I had to hop a bit and lean the bike on one side, but I could cycle. And I was aiming for I cycled every day, and I was a day case for my last hip replacement because I could hop to the toilet on the other leg afterwards and
amazing
and get going. So I know only 1.5% of people are day case for hip replacement, but the critical thing is that if we aim that some people will be, then you reduce the length of stay from 3 days to 2, or from 2 days to 1. Do you see what I mean? So it has...
That has compound benefits, doesn't it?
That.
In terms of reducing risk of infections in the hospital, or, DVTs sitting around in bed.
Absolutely.
Yeah.
But we need to... The problem is, it isn't like the Olympics where you watch it and you think, oh, wow, that Jessica in his heels, amazing. Gosh, I'm just going to sit here on the sofa and eat my chips and watch her. It's kind of... It's what can people actually do to start that will make a bit of a difference. And everything makes a bit of a difference, even if it's, as you say, reducing an infection a bit, or getting out of hospital a day sooner, not necessarily a day case. So definitely needs, that message needs to get out there. I don't really know how.
I loved your idea of bringing it into storylines and soaps, because I was just realizing that actually, like, making it in kind of a background storyline, or normalizing it, that's real change there. And I don't think anyone's ever thought of trying to engage in that. That's something I'm going to take away and see if I can get in touch with a few, just to bring in those kind of normalized, habits and behaviors that we want to showcase. Brilliant idea. Now, in terms of making movement in the perioperative period kind of a norm rather than the exception, who are the key players here? Like, do you think everyone should be involved, from the GP making the referral to the people doing the pre-op assessment? Like, is it everyone, or is there a key few individuals that you think we should target some more training and awareness for?
I think everyone should be involved, including the receptionists, the healthcare assistants, the normalizing it. Everyone involved. Having said that, the really trusted sources do make the biggest impact. So when I was ill, my GP saying, you've got to go for a walk every day, I remembered him saying that and thinking, oh, that applies to me. Okay. So that message. And the difficult bit for me is that if we wait for the physio to teach people things, then the physio might not be on duty that day, or you haven't got the business case to get a physio. We need everybody to say, no, just do it, and then do a bit more, find something. Get up.
Yeah, we can often rely on that. It's like, they're going to see the physio, they're going to talk about that. Yeah. And it puts a lot of pressure all on those appointments. And if we at least start sowing seeds and start building up this kind of narrative, it'll be an easier task, even when it comes to the physio, if they've had people that have been telling the patient the importance of movement. Yeah, so I see what you mean. Okay.
the other thing is it isn't just physios. It should be exercise practitioners rather than, the health physio.
Yeah.
But there are different levels of training, but everyone needs to do a little bit. Everyone should have permission to do that little bit and then bring in the specialist team when required.
Yeah. And do many NHS teams have access to, the exercise professionals and exercise physiologists kind of thing?
So there's quite a few pockets of excellence where they have prehabilitation services. And they have very good results. So it's exercise, it's nutrition, it's talking about such things. But the problem for me is all those people left behind in the places that don't have it. And, some you can kind of get in with sort of a surgery school concept, because then you get a bit of peer-to-peer support and discussion. You and I have talked before about group clinics, that people do get something from knowing someone else is going through something. And I worry about the NHS app being considered the best way forward, for example, because you do need some human in there as well. And particularly a human that understands your medical problems and that you don't feel you're being fobbed off or have something made worse.
Yeah, definitely. And for a lot of people, like the concern around the impact on their health and the complex array of long-term conditions that they may be suffering from, it really does provide a number of barriers. I noticed just so far, you've mentioned a few health challenges that you've had. And clearly the knowledge that you've had has allowed you to overcome many of those barriers. But has health been a stumbling block for you in terms of navigating physical activity and wider lifestyle?
Well, yeah, actually. And I think that's one reason I go and give talks as often as I can, and I write whenever I can. I'm half-time in the NHS now as a surgeon. Because I was catastrophically ill end of 2018. I've got myeloma, cancer of the plasma cells, and cardiac amyloidosis. So those abnormal plasma cells that are supposed to make antibodies or immunoglobulins, the abnormal protein's gone around my heart. And so I had a restricted cardiomyopathy. My heart wasn't, pumping well. So basically I had heart failure and cancer at the same time, which is very unfair. Yeah. And I had chemo for a bit because that's the treatment. I had fantastic care and all that stuff, but the chemo wasn't in my head working. I was still, I get short of breath walking up a few stairs. I couldn't, walk down to the end of the road without stopping to breathe. I could feel my liver, all that stuff. And I knew I wanted a stem cell transplant because that can put myeloma into remission. But I was told I wasn't fit enough because my heart was so bad. And then I found out about electric bikes because I thought, what can I do? Should I go to a swimming pool? I was then driving to Eastbourne Seafront and using my blue badge and then walking because it's flat along and back. And that was, I felt all I could do. But I got an electric bike. And sure, I was still having chemo, getting me a bit better. But I went on my electric bike every day. Rain, shine, hail, everything. I just went out as if it was my medicine. I went out aiming for 45 minutes a day. And I got fit enough. So I made them do a Bruce protocol to see how fit I was, the cardiopulmonary exercise where you go on a treadmill at different angles. And I made them do that. And I have the fitness level then of a woman in her 20s, which doesn't say much for the UK population. But I then had the harvest February 2020, and I'd gone back to work by then because the chemo, worked, and I had lots of, diuretics and things. Anyway, then there was the pandemic, and I was shielding. But then I went the second batch in after the lockdown lifted in autumn of 2020, and I had a stem cell transplant. And actually, the exercise, I kept obviously the exercise over the summer, but it was so good when you're losing loads of weight with the big chemo and everything. I had some muscle ready to use. And yeah, it worked. And I feel like if I hadn't found an electric bike, I might have been dead. And that's quite a wake-up call.
Yeah, no, absolutely. Do you know what, 'cause myeloma at your age as well, is really rare. And so in so many levels, you must have felt must have been gutting to have that experience, but to hear how you use that to, still find a way to, bring movement into your life and use it to improve your chances during the procedure as well as your mental health in that time. Just incredible. Absolutely incredible.
There's something that sometimes suddenly gets people where you think, I can do this. This is what I'm going to do. And you see people whose lives have been transformed when they've had to go through something. Their kid's horribly ill, or you could see something that just kicks in. And I had a kid doing GCSEs and a kid doing A-levels, and I just thought, I can't, this is not my time. But I think people have different needs and wants at different phases of life. And, we need to be slightly careful with some of the treatments around in very old people that have a different view on what they want out of their lives in terms of the treatments. But yeah, exercise for everybody, absolutely should be the first prescription.
Well, thank you so much, Scott. I had no idea of that background, and I've known you for a few years. I already thought you were incredible. I don't know how to describe you now, if I'm being honest. But let's move on, because one of the things that I often get from my colleagues in primary care is we've got a patient, they've been discharged, they're now at home. And if we're going to be talking about physical activity post-operation, and the patient asks, when can I do X, Y, Z? We don't have any training to kind of know, let's say post-hip operation or knee, like when is the right time to talk about these things. And yes, we've got physios that sometimes, the patients will engage with, sometimes not so much. But how can we get it right? Because we're often worried that we're going to get it wrong and cause more harm, and then we'll get an angry letter from the surgeon saying we messed it all up.
Well, I'm sorry, surgeons are still sending angry letters. So basically, the whole surgery is great nowadays. It's the technical bits got better and better. And the aim is that it's stable and safe afterwards. So we get people up and we get people going. There's a few people you have to hold back, like, don't go running on this now kind of thing. But in general, at 6 weeks, you can do anything in general. But building up so that people break up their sedentary time, they move all their joints, particularly trying to walk around a bit, and actually arm weights, getting all of that. It depends what operations you've had, but, arm weights and walking, everyone should be doing, really.
Okay, yeah, got you. And in terms of kind of the pain management side, if people are in still a bit of discomfort and it's potentially inhibiting them from moving, like, should we be relatively, I don't know whether liberal is the right word, but should we be focusing on trying to get that pain sorted to get them moving? Or should we be careful about giving analgesia for sort of too long post a procedure? I know this is maybe a complicated question, but what are your thoughts?
So there's we can have a whole different podcast on that. And actually the CPOC website, cpoc.org.uk, has got things, and we've worked with people on opioid prescribing and so forth. But what I feel is, in the past, we used to say, well, get on top of your pain.
Yes.
And then you can do stuff. And now I think we need to be more honest with patient about, you've had an operation. It is going to hurt. You've got to get moving with it. It's not going to hurt more.
Yeah.
And I remember once all the blocks were worn off after my hip replacement, it was painful, but it was like, wow, that's so much better than the arthritic pain, and I didn't want to take the opiates and get constipated or whatever, but
waiting for kind of pain-free may never come and may not even be achievable. And there may be side effects involved in that process. So, okay. So it's kind of balancing that manageable pain, in that envelope. Okay. Now, would you say that within surgical pathways at the moment, do we have physical activity pretty well embedded, or is there still a journey to go on?
No, there's a huge journey to go. And as I say, the Centre for Perioperative Care has been going for 6 years, hosted at Royal College of Anaesthetists, and many people still don't know about it. And there are many resources there for patients and for staff, including, as I say, reception staff, leaflets for patients about what to do. We've got a video there of Joe Wicks doing some exercises with
Nice.
a patient. So I think people need the practicalities. I think part of the problem with in general, the kind of people who are in charge are the people who do lots of thinking and writing and, having the academic stuff. And actually what you really need are the people that do stuff. So they, you need the practicalities. You need to bring your shoes into the hospital so you can practice walking kind of instruction, rather than let's be nice and we'll look after you kind of instruction.
Now, this may be a strange question, but if I could allow you to redesign the ward that your patients are on, sort of during their stay in hospital, anything that you would do in terms of redesigning it in a way that you thought would help outcomes?
In fact, I avoid having patients in hospital at all. So they're not on the ward. They're having care as a day case. And that gets them going automatically. And the problem is you can put an exercise bike there, but I've been having treatment at the cancer centre in London for 6 years now. It's top-up treatment now. Mm-hmm. And they've got an exercise bike there, and I've only ever seen one other person use it. Okay. So it isn't just the space, it's the humans. We need more human.
Yeah.
You need someone saying, oh, okay, so a bit like, oh, you've had your blood pressure done, right? Well, we need to see what number you can get if you do 4 minutes there. Okay, sit there, off you go, thanks very much. We need someone like that. So it's a bit like it's on a clipboard. You've just got to do it, because it needs to be factored in. Otherwise, people just don't do it. There's a block thinking that you can't or you shouldn't.
Okay, understood. And you mentioned there that you feel like there's a gap and there's still a journey we need to go on. What changes at a system level would most accelerate progress as far as you're concerned?
Well, it's difficult because obviously the amazing prehabilitation services are amazing and they work very well where they work. But it's what happens to everyone else. So if we had all the money in the world and put in prehab services, that would be great. Linked in with rehab and all that. But it's how we get just little messages to get across. So maybe some of that could be in, as I say, in the screening that you have to do when you go on the waiting list, when you have your blood pressure checked or something, there should be something that maybe bringing back what you've done and some accountability. The preoperative assessment service should talk about it, should explain it to patients maybe, but and I think anyone having a major case should go to a surgery school. So that's like a couple of hours, say, on a Wednesday afternoon, so that they learn what they're supposed to do. They learn what the operation will be like, and they meet the other patients having it. They meet some of the team. The surgery schools are probably they should be completely normal, and sadly they're not for anyone having major surgery. So it still feels like it's quite bitty and we need lots of things, but we don't want to suddenly bring in a new initiative for places that are doing amazing work already. And the other thing is then going back to the surgeons, that when people are put on the waiting list, saying, you've got to use that word, you've got to talk about it, because otherwise we're abrogating responsibility, assuming that other people will do it. And I think one of the reasons we hate discussing, you don't discuss obesity or things with patients because you don't want to be accused of calling people fat and lazy by mistake. And my top tip actually is the movingmedicine.ac.uk website, Moving Medicine, because you learn the motivational interviewing skills just in a couple of minutes. I know there are courses, but in order to retrofit that education, people need to be confident that what they're saying isn't bad.
Yeah.
But then also we need to change the staffing so that there's someone in the room next door. So you go, actually, it's really important for you to get ready for this operation. Do you want to see, Rashmi's going to sort it out, go through it. Is that okay? And then they go and do it. You have, healthcare assistants, trained doctor's assistants, people whose job it is to do that. But at the moment, it's also passive and people are waiting for the surgeon to say what needs to happen rather than that shared decision making, rather than that optimization of the non-medical stuff. And then the surgeon's busy doing all the computer stuff. It just feels like we're using the wrong people's skills to do the wrong tasks. But anyway, it does need the surgeons to give permission.
Yeah. Yeah, understood. And do you think do we need to incentivize this? Because a lot of what we hear when I have experts from primary care, they talk about if we want to really start embedding more physical activity into primary care, more conversations, more awareness amongst staff, we need to incentivize it in the same way that we incentivize other targets that we're trying to do in primary care. We use things like QOF and double IF, that kind of thing. Is that something you think in a surgical domain, if they were financially incentivized or incentives in some format, do you think that would make a difference, or do you think that's not really the stumbling block?
So I don't have much experience with the funding in primary care. And the problem with surgery, in surgical clinics, we're just too busy. We've got extra clinics, extra patients. I had 5 different computer systems to get on today, and I had 2 different IT people coming to the room to check something was okay, because last week there was a problem. So all of that takes time, and yet you've got to be nice to the patients. And in the old days, you'd have a registrar in one room, an SHO in another room, a physio in another room, and you just swan around going, "Oh, I've heard you've got dreadful arthritis. Could just show. Oh, goodness me, yes, Dr. So-and-so's explained that to me. Well, blah, blah, blah. Thank you. Carry on." Do you see what I mean? It would be a little bit more. And actually, so we haven't got enough time.
Yeah.
But we could, if we redesigned clinics a bit better, tasks, what do we need people for? They've got good feedback with mega clinics in Northern Ireland and in Wales, because also you need some medical input for some people who have a very high risk of complications for an anaesthetic. People talking to them about, in the shared decision making about whether to go with surgery at all, what the alternatives are, how much improvement could be made, all of that sort of thing needs to be honest.
Yeah.
And at the moment, everyone's too busy, and it's very binary on the operation list, on the waiting list, not. And there isn't enough time. So yeah, actually, you couldn't incentivize my lovely colleagues anymore, I don't think, because we're full and we don't, the money, doesn't, it's a different system, and there are people with pension issues and taxation issues for not taking on more work. So no, but it needs the hospital maybe to be incentivized. Perhaps.
So, it needs to be there needs to be a bit of a restructure in order to build in a bit of space to allow for these things, which in the long term is going to improve productivity and quality. But at the current state, I can't believe that you've got 5 systems you're having to navigate. I thought it was bad in primary care. I think you've got it far worse from the sounds of it. But okay, I want to move us to a positive note.
Yes.
And I want to ask you, what excites you most about the future of perioperative care and the role that physical activity can play?
I think it's one of these things, once you've got it, once you understand the concept, you just can't unsee it. And then it makes things so much better. So the patients have better outcomes, the patients are positive, the staff have a feel-good day. More people being day coaches mean you can do more work, so you increase your productivity. Everyone knows what's happening next. You're not having to manage complications, readmissions, all that sort of thing. So it's cost effective and better for patients, better for staff. Those are the 3, big wins. But basically, it means that the team has a great day and knows they're doing good work, and the patient has a great outcome. It's like what isn't to love about that?
100%. Okay, I love that. All right. So for my final question, Scarlett, if we look at data from the 1960s and we compare it to now, we are sadly, if you look at physical activity as a whole, we're 20% less active as a population. Now, in 50 years from now, do you think we will be as active as we are now, more active, or less active on average?
Inactivity is very related to different inequalities and different groups of people. And so, for example, cycling at any age group, twice as many or 3 times as many men cycle as women. And so we need to fix cycle lanes and improve safety, and have people somewhere you can park electric bikes so that they don't get nicked, all that kind of, and have somewhere to hang your coat when you get to work. So I'm hoping that the penny will drop and that people, the decision makers, will put in the facilities to allow everybody to be more active, because we absolutely cannot afford what's coming in terms of the numbers of older people who are very inactive, who then require a great deal of care, and there aren't enough people to look after them. So I think, as I say, I think it's going to be tough, but I think the penny will drop and people will have to become more active, because we can't manage otherwise.
Brilliant. Thank you so much, Scarlett. Really appreciated your insights and sharing your personal story as well. Thank you so much.
It's been a pleasure. Thank you.
That was Professor Scarlett McNally sharing such a clear and compelling case for embedding movement throughout the surgical pathway. For me, the key takeaway is simple. Fitter in, faster out. Supporting people to move before and after surgery isn't an optional extra. It's often one of the most impactful, low-cost ways we can improve outcomes, reduce complications, and help people return to the lives they value. If today's episode has sparked ideas, think about one small change you could make this week. Perhaps starting the physical activity conversation earlier, signposting to local support, going on the Moving Medicine's website to have a look at their 1 minute and 5 minute motivational interviewing structured consultations. If you enjoyed the discussion, please subscribe, share with colleagues, and leave a review. It helps more clinicians discover the podcast and keeps the movement growing. Until next time, remember, movement is not just prevention, it's treatment, rehabilitation, and recovery too. Thanks for listening to the Movement Prescription Podcast.
Hi, it's Callum. I really hope you enjoyed the episode. We are so grateful to the British Society of Lifestyle Medicine for their support in producing these podcasts. And we wholeheartedly share their vision of transforming healthcare and levelling health inequalities through lifestyle medicine. If you want to find out more, please head to bslm.org.uk. Although catering for healthcare professionals, this podcast is for everyone. If you enjoyed it, please share it. And we love hearing from you, so do reach out. Thanks for listening.